Erin Lanahan, president and founder of Point Insights. This series reframes what a healthcare campaign is for. So today we're going to talk about the fact that the old scorecard, did you hit the dollar goal, is necessary but no longer sufficient. The through line of today's session is the shift from goal, a one-time revenue target, to growth, a lasting increase in fundraising capacity. So everything that follows that Sarah and Eric and I are going to talk about is organized around the following two questions. What does current practice look like in our field? And how do we use these insights to define and refine campaigns in a way that leaves our shop stronger and more capable of sustaining performance after our campaign? So today's webinar and the entire campaign survey series could not have happened without the partnership of two very special organizations. The first is the Association for Healthcare Philanthropy, AHP. Back in early 2024, AHP convened a large number of us in Colorado to talk about campaigns. And at that summit, one of my personal highlights after all the educational sessions and the robust discussion and debate was actually a moment where I got to cap off the learning with the two leaders here on this call, Sarah Krasin and Eric Javier, who graciously allowed me to crash their lunch. And at that lunch, one of the things that really stood out to us, there was all these great best practices being shared, all of these challenges being worked through, but not a heck of a lot of data for our field. There wasn't current data and not a lot of data specific to hospitals and health systems. So we talked about, wouldn't it be great if we could do something together? And so now 2 years later and change, we're so happy to be able to share with you some of the highlights. Eric and Sarah, thank you so much for joining us this morning. I'm just going to give you a very brief intro, but Sarah serves as the managing partner for the West region for CCS. And prior to this, she actually was the leading CCS's Boston office. She was overseeing so many of those partnerships in the Northeast, but we are thrilled to have her back on this side of the country. Welcome back. I feel very lucky that you're going to get to work with some institutions and continue to strengthen nonprofits right here in Southern California. Eric oversees CCS's Northeast region, which is my original home. So I'm also very happy about that. And Eric, it says here you've partnered with more than 300 nonprofits across your time at CCS. So clearly, Eric, one of the questions I'm going to put in the chat later, the Q&A, is how he's found a way to create a tear in the space-time continuum so that he can do all of these things at the same time. Together, Eric and Sarah have just an extraordinary knowledge of the dynamics of healthcare organizations, of campaigns, and of what it takes to make and sustain real change. So if Twin Point's data is going to capture the what of current practice across our field, and we're all going to discuss the so what, Eric and Sarah are going to offer the what next, considerations for the hundreds of institutions on this call. So speaking of the institutions on this call, we're also always curious to see who is joining us. And I'd love to ask folks to contribute to this short poll. What kind of organization are you here representing today? So we can see overwhelmingly 83% folks here from hospitals and health systems representing development. And so we're really, really especially thrilled to welcome all of you today because this is for you. This research is for you. So I want to preview the arc of today's webinar briefly. We're going to start by setting the stage. We're going to talk about why campaigns have become so essential to hospitals and health systems today, as well as the impact that hospital and health system need has on your campaign goals. We're going to dice this a few different ways for you because this is the most comprehensive data set ever assembled in our field about campaigns. So we're pretty excited about that. Then we're going to talk about 6 facets of successful campaigns and where the gaps are in the field. Now, I also just want to take 1 second because I know we have some new friends on the call today, and I want to reintroduce the Healthcare Campaign Survey Series. So, this is a 5-part series that is designed to explore key aspects of hospital and health system campaigns, from priority setting to volunteer strategy to donor relations, the post campaign period. There's a lot. This series was administered in partnership with AHP and our series sponsors from the fall of 2024 through January of 2026. And in case I didn't make this explicit, CCS has served as our Platinum Series sponsored. This series simply would not exist without the folks on this call today and the many, many folks behind the scenes who have made an investment in this thought partnership. So we are so grateful on behalf of the field. So a few months, just going back to the frame of the survey series, so we administered these across the course of months, and then a few months after each survey, we published a quick hit executive insight report available to anyone, and those still are, and I'm going to give you a QR code for them. Twin Point's flagship report is coming out later this year. Series participants are eligible for complimentary copies, and others are, if you haven't participated, you're still able to get the data through AHP stores. But the most important thing about this series is that it's by the field and for the field. So when we say by the field and for the field, we mean hospitals, health systems. We might use foundation and development office interchangeably, but the great thing about such a large data set is that it includes them all. Academic medical centers, children's hospitals, large shops, small shops, Canadian foundations, US foundations, 501c3s, development offices. In other words, there's probably an organization like yours in this data set, if not several. So let me show you just a little bit about the 146 respondents that have joined the series so far. Each one represents a distinct hospital or health system campaign. The majority are US, but we do have a healthy Canadian cohort as well as one Swiss hospital. Salut, mon ami. Because of the consolidation in our field, most campaigns are raising money for organizations that encompass multiple entities, most often community hospitals, but we also have health systems, cancer centers, academic medical centers, behavioral health facilities, home hospice, and others. So we really like to see this kind of representative breadth. Okay, again, just briefly, I want to share that the campaigns do skew comprehensive. This is a question we get a lot. But about 1/3 of the campaigns in our data set are focused on capital still. We allowed organizations from all campaign phases to participate, including those that had closed a campaign in the prior 5 years. And the largest group are from campaigns that are in the public phase. Okay, so this next screen is probably where, as we talked about, we're going to start to see some screenshots. The median campaign in our series had a $90 million goal. $90 million. All of these are in US dollars. I have a footnote there about the conversion factors that we used. That said, about 41% of the campaigns in our series had goals of under $50 million. So what we like here is that we see really good representation across all different types of campaigns at all levels. And in a minute, Eric, Sarah, and I are going to talk about how we see goals really skewing upwards. So again, that is just a flavor of an enormous, enormous data set that we have for our field. There's a lot of ways we can slice this data. Here's a QR code where you can download the data we've already published. You can register for other webinars. You can receive an email when the flagship report is published. But most of all, I hope you will raise your hand if you'd like to join a cohort level conversation. So this is Twin Point's Campaign Catalyst. It's a community of practice where we will pair data deep dives with peer consultation. So together, you'll get the opportunity to design your own cohort level dashboard that leverages the robust data already collected in the ways that you find most useful, as well as to ask each other and problem solve together about issues in campaign. Again, I should have said this at the beginning. I am not a consultant. I am our healthcare philanthropy researcher for our field. I love this work, but I am also a matchmaker and I love to get a chance to get people in the room talking about these issues. So I hope that some of you will join us in follow-up. Okay, in some ways it feels like a lot of preamble. Now we're going to have a moment of pause. We need to talk about how philanthropy has become even more essential to how hospitals fund their futures. Increasingly, underwriting not just equipment and technology, but transformative capital needs, projects, community health initiatives, research, and more. You know, the three of us on this panel have been working in healthcare philanthropy for a few decades, and this is about as serious as we've seen it. So this is a slide that CCS uses in its field work with its partners, and we really appreciate the chance to show you just a little preview of their thinking on this issue. So we're going to talk about both US and Canadian hospitals because there's a lot of parallels going on. Among US hospitals, margins have been hit hard by a combination of regulatory changes and economic headwinds. Debt financing is harder to come by. And what's interesting is that we've seen consistent philanthropy making a difference in the actual bond ratings. So if there were ever a moment to convert your CFO and your CEO to being an advocate for philanthropy, wow, when it shows up and you bump up into that, AA rating or beyond, and philanthropy is actually a line item in those organizations that we see that have consistent performance. Well, across the field, as we said, things are really challenging. This is an opportunity for philanthropy to step up, to go from being a nice to have to a must have. And that's true in Canadian hospitals as well, right? And that's true for a few reasons. In Canada, I would say the top reason is that provincial government funding simply hasn't kept pace with what hospitals need, right? So we see this, the three of us on this call, they don't fund aging equipment. They don't fund research infrastructures, many of the capital projects or innovation initiatives that are needed. And although hospital spending in Canada has actually grown in absolute dollars, today hospitals receive a smaller share of overall spending than in previous decades as provincial governments expand priorities to fund drugs, mental health, home care, long-term care, right? Medical equipment on both sides of our border has become dramatically more expensive. So 25 years ago, replacing an MRI was a major campaign. But now we have precision oncology, robotic surgery, and more. Many of these technologies evolve faster than government capital funding cycles, what payers provide here in the US, and what our institutions are able to sustain through debt or operating dollars. As in the US, Canada's major academic medical centers compete internationally. Philanthropic dollars are the risk capital that allow hospitals to move first. And finally, we both have populations that are older and sicker, which creates pressure for more equipment, space, and specialist programs, some of which foundations are being asked to fund, right? So if you're feeling this pressure on the call, you're not alone. It's no surprise that many of our institutions are turning to campaigns to capture this needed funding. So I actually want to ask how many of our hospital and health system institutions that are joining us on this call are in campaign. And we have a few different phases. The chatty campaign, sort of you're talking about, planning for a campaign, a planning phase, silent or leadership, public, or maybe you recently ended a campaign, let's say in the last 2 years. And if you're unsure or other, there's a spot for you as well. So this is just for the hospitals and health systems. All right. So I'm going to say this verbally for the folks who might be dialing in from audio, and while we're waiting to share, okay, let's actually go ahead. I'm going to share the results with everyone. It's really interesting. We've got the pretty good split, almost a third in planning and a third in silent or leadership, 20% in public. And some folks who are, really early in the process, I would say if you're really early in the process in that chatty phase, or if you've recently concluded, you're actually in the same phase. That's what we see across the field, right? That you're it's sort of the Oros Boros, right? It's it's restarting the whole cycle. But yeah, I mean, this is, most of the hospitals that are on the call are in some phase of a campaign. Yes, it is self-selected, but what we would really emphasize here is that the data bears out that this is what's happening across hospitals and health systems and even beyond, right? So being in campaign has become sort of a permanent state of operation. Eric and Sarah and I were talking about this, thinking back 20 years ago. So when we were bright-eyed and bushy-tailed, and they were newer, consultants, and I was a philanthropy researcher, and I was listening to a lot of indie music. I will not call out their taste, but on my end, so in calls with chief development officers and in the conversations that they were having, we'd hear that campaigns were something done maybe once a decade, maybe slightly more often, and that in any given market, the major nonprofits would take turns. How nice of them. First the university, then the hospital, then maybe the house of worship or the social services organization. Yeah, that time has passed, right? So even when we look at hospitals and health systems across the major benchmarking initiatives in our field, close to half of you self-identify as being in campaign in any given year, whether it's AHP's report on giving or AAMC GIA's annual development benchmarking. Campaign is no longer an episodic event a shop mounts once a decade. It's closer to a continuous operating condition, which is exactly why building durable capacity matters. And more is being asked of development shops at all sizes. So this is a chart that it is a logarithmic scale. I promise we'd not get too nerdy, but it's just to be able to have everyone on the same chart. For those of you with very good eyesight, you can see that there's a number of nine-figure campaigns that are trending around organizations with 100 plus development FTEs. We use AHP's terminology here, development FTEs, direct development fundraising FTEs, those in the front of the house, and indirect development FTEs, those in the back of the house. So everyone in development. This isn't 100 major gifts officers. This is all in, right? What's interesting is that you can see there's actually a lot of variation in campaign goal for development shops with 25 or fewer FTEs, right? Those small shops, 0 to 10, we have goals ranging from $5 million at the 25th percentile to $34 million at the 75th percentile. And for the mid-sized shops, that range, the 25th to 75th or interquartile range, is 22 million at the 25th percentile to 169 million, right? And that's for shop of approximately the same number of FTEs. So what is behind this variation? Differences in institutional priorities, philanthropy's profile within the organization, one-off campaign structures. For example, there are a few outliers where hospitals are using a targeted sprint campaign. But again, we're not just focusing on the outliers here. We are looking at core trends. And what the three of us on this call find is that goals are going up. Now, we want to be careful. It is not just a plug and play number that X fundraisers is going to get you Y number of dollars raised, right? There are other important elements at play in both designing and attaining your goal. That said, we all acknowledge staffing is extremely important, and we know you want to see this sliced by shop size. So here it is by staffing band. Now, I want to say you'll see these are medians. You'll see a lot of medians in our data from Twin Point because we try to smooth out the variation we would see from outliers, right? But when you look at the 50th percentile for each staffing band, a pretty clear pattern emerges. Every rung of the staffing ladder roughly triples the campaign goal, right? So for those listening in and not looking at this graph, medians climb from about $5 million at the smallest shops towards $500 plus million for those who have 100 plus FTEs. So that's conclusion number 2. There is a real predictable relationship between team size and campaign goal. At the same time, Shop size is not destiny. Um, but across the board, campaign goals have been rising for everyone. Sorry, I paused because there's one more poll that we want to have here. So we are curious as we go, before we go into our next slide, I'm really curious. We've seen a lot of same institution growth among campaign goals. So if you think about your current campaign and you think about your organization's last campaign goal, how do the two compare? Is your current goal about the same? Is it smaller? Is it bigger than your last campaign goal? Is it significantly larger than your last campaign goal? This is a chance for you to yell it into the void, as it were. These are all anonymous. I know sometimes we need that. We were going to have a poll about how do we blow off steam. And if we have time, I'll still launch that at the very end. I promise, Sarah. We're always looking for good ideas. So yeah, I'm going to go ahead and I'm going to give people, yep, we still have people answering. So I'm going to give people one more minute. What do you, Eric and Sarah, what would your prediction be of the bit? There's a group that is dominating here, 50%, one answer.
Significantly larger.
Yeah,
Am I right?
got it in one. Got it in one. All right, so I'm going to go ahead and share these results so that we can keep moving along. Yeah, so we found almost half of folks. Your goal is significantly larger for this campaign than the last one. Another 13% say somewhat larger. Interestingly, 10% about the same, 4% somewhat smaller. I would say, based on our survey data, but also our qualitative research, and we had over 120 interviews in this project. That's for organizations that are coming from a comprehensive campaign going into maybe a targeted mini or sprint campaign. That is why we see that smaller campaign. So yeah, when we looked at our organizations, when we looked at the same organization data, right? We see that hospitals are setting higher goals for themselves. So when we compared the current campaign goal to each organization's last campaign funds raised, at the median, the current campaign target was almost 3 times as large as the last campaign, and that's the median, right? So for half of organizations, they were reaching even higher. We have campaigns in our data set that are 10 times their previous goal. So this is another one of our teaching points. The goal arms race is showing up in our data here and in another interesting way. On the right of the screen, we separated out the median campaign goal based on campaign phase. Found something really funny. Those who are in the planning phase are aiming even higher than those that are in the public or silent phase, right? So in our data, survey respondents who reported on a recently concluded campaign had a median goal of around 15 million US. But for hospitals in the public phase, the median goal shoots up to 95 million and the planning phase 131 million. So sure, there are some differences among organization types, campaign types in this data, but the trend line is the takeaway. Hospitals are being pushed to increase their campaign goals. And often it's not done with as much rigor as we'd like. Just want to share a story here, and we all have, stories like this. A few years ago, I was speaking with a high-performing hospital, community hospital system. They had done a comprehensive effort to look at their market, look at their campaign priorities, look at their wealth, and assess what an appropriate but still ambitious goal might be. And they came up with a number of $250 million. They brought this to their health system CEO for approval, and he said, nah, should be 500. That wasn't based on anything more rigorous in the market. They hadn't done their numbers wrong. It was based on institutional need and frankly, a misguided sense of the comps who are in the market. So when we have these campaign goals sort of arms race, we start getting our board members and our executives who are pushing us for larger and larger goals. And we're going to talk about this. Now, deep breath. The good news is that organizations are hitting these increased targets. And again, on the surface, very good news, particularly for the hospitals that rely on us. The challenges, as we're going to lay out, In most development shops, we simply aren't meeting these goals in a way that is going to allow us to sustain our performance after the campaign. Too many shops that we see are limping across the finish line and then being told, lace up your boots, you're going to run another marathon, right? The way we've gotten to the finish line, relying on principal gifts, neglecting pipeline and other factors, isn't part of building capacity for sustained performance. So that's our thesis today. Meeting our revenue goal is no longer enough. The high performing campaign leaves behind a stronger fundraising engine than it found. So now we're going to pivot to both the so what and the how to. This is Twin Point's framework for high performing campaigns, which we drew from over 3 years of qualitative and quantitative analysis. The high performing campaign leaves behind a stronger fundraising engine than it found. And the best shops, the highest performance shops, treat the campaign as a catalyst for lasting capacity, not a one time sprint, right? Most are actually over relying on principal gifts to help meet their campaign goal, where we need to see capacity building showing up in 5 areas: priorities, partnerships, people, processes, and pipeline. That's the order that we're going to approach things for the rest of today. So, Sarah, thank you for your patience as I shared our collective insights in this area. One thing I found really interesting in all of our pre-webinar sessions was this idea that you said clients increasingly come to you for growth planning, not just campaign planning. So what's driving that? And what does a growth plan include that a traditional campaign plan doesn't?
Thanks, Erin. And hello, everyone from beautiful Los Angeles. Really happy to be here. And Erin, thank you so much for your leadership of this research. I think we've learned a lot at CCS along the way, too. And this question about what is a campaign plan versus what is a growth plan is an important one. Erin, I so appreciated the discussion you were leading in the first half of the webinar about how campaigns historically, if you wanted to grow philanthropy as an institution or you needed to accomplish a big project, you would wait your turn in the market and you would launch a campaign, and then you would go back maybe to business as usual and then launch your next campaign. And that is, as you just mentioned, is no longer the case. So a campaign, as we often say to our clients, is nothing more than a tool. It's not the institutional strategy. So if your institutional strategy is to ensure that philanthropy is a sustainable and growing part of your financial model, per some of the comments you were making earlier about why that's so important to hospital leadership, you do need to think a little bit differently than episodic campaigns. So when we think about the difference between a campaign plan and a growth plan, campaign plan, which of course we still do plenty of, and campaigns are great tools. They work, right? That's why so many of you are doing them, joining us on the webinar. But a campaign plan answers moment in time questions, right? So can we raise a certain amount of money within a specific time box? What are the priorities that are really going to resonate? How should we launch and when? How do we think about using perhaps once in a generation projects to anchor the notion of a traditional campaign? Growth planning, though, offers, and allows us to answer a much broader set of questions. So do we have, for example, the leadership and staff and talent to support long-term growth? So after we're done with campaign growth, can we sustain that level of performance? And how are we investing in our talent and our team to ensure that we're able to do so even after the perhaps confetti cannons have been shot off at the end of our campaign? The second piece, again, I know we'll talk about this later, growth planning really involves thinking about not just the gifts secured in a moment in time, but really more about your healthy pipeline at every level. So not only thinking about gifts that donors are going to make in this particular campaign, but gifts, thinking about the donor lifetime value of everyone in your prospect base. So they may not make their ultimate gift in this campaign, but what needs to be true for them to make their best possible gift or really prioritize you differently? And then finally, I'd be remiss, Erin, to not mention the impact on data and technology and operating process in our field. Fundraising, of course, remains the combination of art and science. I think at CCS, again, we've just seen the power of investing in analytics, about thinking about some of the tools that our for-profit colleagues have been using to great effect for many, many years to project revenue, to predict performance. And again, we're seeing just amazing talent coming into the field around data science. And so again, using that and making it part of your fabric of your day-to-day operation, not just a capability that you bring on to set a campaign goal. So again, they have a lot of the same qualities, Erin, but I think most institutions at any level, even if you're doing campaign planning, you can benefit from taking a growth planning lens as you go through that initial, chatty phase of your campaign or your planning phase of the campaign.
Yeah, really beautifully said. I think that we can no longer afford to plan for just just the end in mind is not just those confetti cannons, right? Which, by the way, in Los Angeles, we're very anti any kind of cannon that could start a wildfire. But I think our institutions just have such great need that we need to be thinking on those longer time horizons. And as you referenced, and I love a discussion of a blended gift or a planned gift, right? We also want to be partnering, thinking with donors about they're hopefully not going to just be a donor for this campaign. They're going to be a partner in investing in the future well beyond this campaign if done, if done right. So thank you. Let's dive into one of our first P's. I want to talk about pillars or the levers or facets of campaigns and what's actionable. And the first one is something we were surprised to see how much hospitals were struggling with, and that is setting compelling campaign priorities, right? So most hospitals are being asked to raise their largest ever goals with a murky set of priorities. Half of respondents in our data said that establishing donor-ready priorities was somewhat challenging, and almost a quarter said it was very challenging. Fewer than a third of respondents told us it was easy, right? And part of that difficulty lies with our hospitals and health systems. Our C-suite colleagues may be struggling to commit the capital or debt a priority requires. In fact, in interviews, we're hearing increasingly that organizations are saying they're being asked to support projects that won't happen without philanthropy, and maybe even some of the projects are being funded entirely through philanthropy. In how are organizations threading this needle? How are they managing these largest ever campaigns when the projects aren't totally in focus? Well, it's interesting, and we have another one of these dot charts, but it's meaningful. In our data, larger shops with bigger campaigns are responding by launching with broad campaign pillars. Think innovation or access, right? Coloring in the details later. Smaller campaigns by revenue size, many of which include capital campaigns, tend to offer very granular project level priorities from the get-go. And this is a slide shows you an analysis that we did looking at all of the different pillars that people shared with us, and we categorize the pillars as broad, on a range of very broad all the way to very, very specific. So pillar architecture is a strategic choice. Breadth buys you flexibility for some of the big complex campaigns, and specificity drives urgency and tangibility and may be especially appropriate for capital needs. You have to match the approach to the campaign's scale. So I want to move on to the second pillar because this is probably the one that gave people in our study the most heartburn and where there was the most difference between the conversations we had at the campaign summit, the conversations in focus groups and in qualitative interviews, and then the actual data. Many of our interviews suggested that they were considering a totally new approach to engaging with volunteers in campaign, and that was not setting up any campaign-specific volunteer groups. But then our survey showed that most have not moved away from that, right? Over 2/3 of respondents tell us that they're still using campaign-specific volunteer groups. Apparently, news of the campaign cabinet's death has been greatly over-exaggerated. That said, few hospitals are standing up other campaign-specific volunteer groups beyond the campaign cabinet, such as physician and employee committees, and that's on the right hand of the screen. So we concluded that the campaign cabinet remains the default, and that's not wrong. But the campaign cabinet is a rare window, excuse me, the campaign is a rare window to intentionally redesign volunteer structures, and most shops aren't seizing it. So this question is for Eric. I want to play devil's advocate for a minute. We hear that managing volunteers can be both rewarding but incredibly time consuming. These are critical relationships. We know that less than 30% of our shops, of shops in our data have a dedicated staff member to work with volunteer leaders, and that these structures can consume both time and bandwidth. So I don't want to say convince me of the power of the campaign cabinet, but how I'm curious about how you work with hospital partners when using a campaign to reset expectations around partnership with volunteers, to reset maybe a structure or a dynamic.
Thanks, Erin. Yeah, I think, the qualitative conversations and the conversation we had back in Colorado, a few years ago, I think in between sessions or, at happy hour, I think everyone is glad to talk about how difficult it can be to sometimes manage volunteers. And I think maybe we were all more truthful at happy hour than we were in the survey. And so for a couple points on this, just briefly, knowing we have a lot to get to, I think one, we have to acknowledge that there is great value in volunteer engagement when it comes to personal giving. And so we know there's a lot of research that shows that those who volunteer tend to give bigger gifts than those who don't. And in a lot of ways, there is no greater form of volunteerism than serving on a board or leading a really important and large initiative like a campaign. And so I think it's important that we acknowledge that. I have an example of a current client who's been on a long-term campaign who had a campaign chair whose previous gift to the institution was a grand total of $0, but ultimately gave a $5 million gift as a first-time gift to this institution, obviously because of experience, but because they took on the responsibility of leading something that was really important to them. Now, it's very hard to go from 0 to 5 for most people, but I think it's a great example of what engagement does to giving. The second point I'd make is that, this notion of a campaign cabinet, it's not monolithic. And that I think what we're seeing at CCS is that there are many different flavors of what a campaign cabinet or campaign volunteer group can look like. Two quick examples. One, working with a healthcare system where they're engaged in a very long campaign, 8 to 10 years, but the campaign has multiple phases, and each phase purposefully had different campaign chairs or co-chairs. So when we say campaign cabinet, let's not plan or think that it's got to be the same group of people for 7 years, which is exhausting for both staff and the volunteer. And then the second and final point I'd make about these cabinets is that we know that there's great value in engaging volunteers for a lot of different roles. We already talked about the donor role, but the door opening power, the convening power, being an ambassador, being a spokesperson, and to mobilize volunteers in those different roles. Again, it doesn't mean people need to come to a monthly meeting where they're bored out of their heads, but there are a lot of creative ways that a lot of hospitals are mobilizing volunteers, and it may be by name a campaign cabinet, but the way they're engaged, the way they meet, the way they convene can be a lot more creative and a lot easier to manage.
Absolutely. I love this idea, and I've been hearing this coming through in the field of having right, it can be called a campaign cabinet, but that doesn't mean like we can define what that means, and we can and should be clear in our expectations though of our volunteers up front. And so in our data, we have a whole survey that was completely dedicated to volunteer leadership in campaign, a little bit out of campaign as well. And we ask about written expectations. We ask about how those discussions, how, are set up front, who goes to the meetings, the initial, conversation with the volunteers. And I think that this is going to be really important to customize as we're talking about the next generation of volunteers, right? Um, who have this passion for our institutions and for the field, but they don't have the time or the inclination necessarily to come to a series of meetings, right? And you referenced this, so I just want to share this briefly before we move on. Absolutely, volunteer leaders punch above their weight on some of the most sizable gifts to our campaign. So we asked the respondents in our survey to tell us about just the single largest gift in their campaign, right? In 20% of the campaigns, a volunteer leader was the donor of the largest gift. And beyond that, in 39% of campaigns, a volunteer leader played a significant role in securing the top gift, whether it was making that initial introduction or going to meetings to talk about priorities, right? Volunteer leadership isn't purely ceremonial. It is materially tied to landing those lead gifts that make or break a campaign, which is why the work that we do around volunteer leaders will always matter. So, humming along, our third P is people. We think about, yes, volunteers are people, but we think about the people in our shop, and let's really focus in there. I was again surprised and a little concerned, especially when we think about the large goals that our organizations are being asked to attain. We think about campaigns as opportunities for organizations to ramp up staffing wise, and that is not what is happening, right? So among shops that added staff, the median was just 3 net new fundraising FTEs, so net new positions. Staffing mix matters. So for 54% of hospitals in our survey, they were able to add both direct and indirect FTEs when they're preparing for a campaign, but about a quarter didn't add any staff, or they're still deciding. And some added only indirect or direct fundraising FTEs, right? And I know folks are going to ask about if there are specific ways to slice this data. Absolutely, that's part of what we want to do in those cohort level discussions in Campaign Catalyst, because that's where it really matters that you're with like organizations, but we have a lot of that data, right? So this means our hospitals are going after campaign goals, often much larger than any previous ones, with only modest staffing increases, which puts a premium on hiring the right staff. And there is one staff role that gets disproportionately added in campaign, and that's major gifts officers, right? It's the only bar in orange here on the screen, and that's because new fundraising FTEs are overwhelmingly allocated to major gift positions. So that helps us to make our goal in the short term, but it starves the pipeline in the long term. Right? And the second piece is, although the right of the screen, which shows our new indirect fundraising FTEs, on the surface, it appears to be more evenly dispersed, right, between donor relations, Marcom, data analysis, prospect research. But in practice, again, organizations may only be adding one indirect fundraising FTE, and that means they're making some very tough choices. For example, far too few organizations are able to add to their data management team, which has implications not only for issues like campaign reporting, but may leave organizations really struggling to meet the demands of the AI era. So we often get asked about this mix between front of house and back of house staffing, to use a restaurant analogy. I think we'd agree that very few chief philanthropy officers feel like they're able to add as many staff as they'd like or need, especially in the current environment. How do you help organizations make the case for anyone outside the front line, anyone beyond an MGO major gifts officer who often we see as having maybe the ROI we're able to wrap our brains around. How do you make that case?
Yeah. Yeah. Thanks, Erin. Yeah. I mean, first, let me acknowledge that both roles, front and back of house, are so crucial, right? And I think it's important to honor that. I think making the case for those our friends on the webinar, as you're thinking about approaching your hospital leadership and making the case, I think it begins with really a level of education that I think should be tied to the ambitiousness of the goals, right? So, if we're going to raise the type of dollars, if we're going to secure the level of gifts that we know we need to achieve these ambitious goals, we without a doubt need capable people who can go out, build relationships, and solicit those gifts, major gift officers. But to raise the type of dollars, you also need great writers. You really need skilled people who are great at donor relations and stewardship. We need the expertise in data analytics to make sure we're focusing on the right people at the right time. We need great researchers to know where, like how much to ask for, when to ask for, how to frame the ask, the right timing of the ask, et cetera. And the list goes on, right? And so these are activities that I think we can all agree we don't want a major gift officer focusing on because one, it is not their core strength. And two, there's a huge opportunity cost. If a major gift officer has to write every proposal, then that means there's less time in actually building relationships and soliciting gifts, et cetera. But the closing point I'd make, Erin, is that it's going back to our main thesis that we need to use campaigns or view campaigns as achieving immediate revenue success today while also building the capacity for the long term. And when you have great stewardship, when you have great communications, when you ensure just a remarkable donor experience, you know that there's going to be a level of giving that is sustainable and that becomes a platform for your next campaign and ongoing assertive fundraising.
Yeah, I think that is so critical to keep in mind. And at the same time, having worked in an academic medical center, on a campaign staff, there is this relentless pressure to meet these campaign goals, and not just the broader campaign goals, but it's not just about the numbers, but about the conversations you're having with superstar, researchers who are saying, this funding is going to be the make or break for my work, especially in the current climate. Or, people want to be able to. It can be difficult not to overly emphasize the here and now, but absolutely, we need to have the long term. And we need to do the nitty-gritty work, right? So while staffing and other investments aren't always in our control and development, there are other elements of core processes that very much are and have to be attended to, even the unsexy aspects, right? So this is the kale. I live in LA. This is the kale of campaigns. I want to acknowledge it. We have to attend to the kale, both for the sake of campaigns and in preparation for the post-campaign period, right? So our organizations, this is some sobering statistics here on this slide, even though we have these very happy little icons as well, right? Our organizations are failing to tighten processes at exactly the moment that those processes are being stress tested. Only 57% of organizations maintain a campaign budget or a dedicated cost center. Only 46% audited their database before they launched their campaign. Only 41% significantly revised their donor recognition policy. 39% made a major technology investment. 16%, only 16% of a data governance committee. This is the piece that gave me pause. Only 15% track campaign ROI. To me, this is because most shops don't attribute expenses to the campaign at all. So, Sarah, I wanted to ask you, beyond hitting the number, right? Everyone's looking at the number, the top, number. Beyond that number, how do you coach organizations on how to know whether a campaign actually made them more effective? If a leader wanted a quick diagnostic of their fundraising engine's health, what would you tell them? Where would you tell them to look first? Sorry for, I just am so fired up about this.
No, yeah, me too, because I think we've all sat in a boardroom where we are asked this question and sheepishly rifle through our Excel spreadsheets and notes and try to come up with some sort of compelling answer. And Erin, I'll just call out what Eric mentioned in his last answer, which this is a balance, right, between driving immediate performance because our institutions are under a lot of immediate financial pressure and thinking about building the engine for the long term. Otherwise, you're just in the same place you started when you exit your campaign. So just a couple of thoughts in the interest of time about when CCS does things like mid-campaign or post-campaign assessments, and we're asked to really provide some quantitative frame to these questions. A couple things that we always look at and encourage you to look at too, if you're planning for or in the midst of a campaign. One, did donor retention improve at all levels of the pyramid? And not all levels are, of course, created equal. But for example, CCS benchmarking in healthcare, we find that 6 years out from a cohort of major giving, so a donor made a major gift, 6 years out, less than half, 49%, are still giving to that institution. That's a major problem. It's a tremendously scary expression of the dollars up, donors down phenomenon that we're all thinking about. So is your donor retention improving or at least staying steady both in and out of campaign? Did the pipeline strengthen? Do you have entries at every pipeline level? Again, when you look at the landscape, it's no longer that people need to enter through the base and take 15 years to go all the way up. There are opportunities for people to enter at every level of the pipeline. And then finally, leadership access timely and reliable reporting, right? So to your point, Erin, when development leaders don't always control staffing budgets, and I have yet to meet a chief development officer at a hospital who said, yep, I got every staff position I wanted for my last campaign. What we can control is many of the operating practices that drive performance. Policies, database quality, reporting discipline, and that is a worthwhile investment so you can tell that story and be in a strong place to advocate for the resources that you want. So retention, pipeline acquisition at all levels, and can you do clear and reliable reporting, and is that going to be a legacy of your campaign?
That's fantastic. I advanced to this next slide only because I wanted to show the right-hand side in particular, which is we spend so much time focusing on that one top gift, right? That one make or break gift. We have that on the left-hand side of the slide here. So we have this huge concentration of lead gifts. At the median in our data set, the single largest gift accounts for 15% of a campaign's total revenue. But we're neglecting this incredible influx of commitments from new donors and even from existing donors. So to your point, Sarah, really thinking about what is the impact that a campaign has on the pipeline, and then how do you actually activate? How do you activate that promise of that pipeline, right? And retain those donors. So the data on the right suggests that a campaign is likely to bring in hundreds or even thousands of gifts. 61% of hospitals and health systems in our data found that their gift volume did increase after they launched their campaign. And for almost a quarter of hospitals, this increase was significant, was more than a 50% rise in gift volumes. Right? So absolutely donor retention is something that we have to pay attention to, and it's essential for that post-campaign sustained performance, right? I want to move on just briefly to the next slide here, just in the interest of time, and we can always move back as well. Doing so, activating the promise of those donor relationships requires a lot of intention. And one element that hospitals are working on is to modernize our conception of donor recognition, right? Too many rely on one item on the menu, physical naming opportunities. You can see it's in the upper right in terms of how prevalent it is and how our survey respondents rank its effectiveness, right? It's considered by far to be the most effective tool. But campaign priorities are becoming a lot more diverse, so even major campaign donors might be giving to a priority that doesn't correspond to a named opportunity. Second issue I just want to raise is even within naming opportunities, there are other challenges that our development leaders are navigating. Are we going to allow donors of planned gifts or blended gifts access to naming opportunities? What steps should we take when our buildings or units must be renovated or demolished entirely? I was up in Calgary at Convene Canada. This conversation was coming up a lot for organizations that were in the enviable, in some ways, position of building a new hospital, but asking what are we going to do about our plaques and our legacy and our history, right? Donor relations is about securing the gifts you already closed and stewarding donors for new gift. So we have a ton more data on this in our donor relations report. Would encourage people to register for those executive insight reports. I also want to show this sixth piece, which is about persistence, right? So by persistence, I don't just mean the effort that you all are putting into fundraising. I'm also actually talking about statistics here, right? Highly persistent data means that past actions have a long lasting effect on future values. And that's just what I think is happening here. So if we truly work on our Ps, if shops genuinely execute on priorities, partnerships, people, processes, pipeline, not just principal gifts, then they can deliver persistent performance that our hospitals and health system needs. And that's what turns a campaign from merely hitting a goal into consistent and reliable growth. And what you've told us is that your executives, your C-suites are expecting that performance. So almost 40% of survey respondents told us that they believe their hospital executives will want them to maintain their campaign fundraising rate or increase it. Wow, talk about, ending a marathon and then, going on a 50-yard dash. A similar percentage of you think that executives will allow for some fall off from a campaign, but not going all the way back to the pre-campaign rate. So there's going to be a new normal. Eric, I want to throw things over to you as we're coming up to the top of the hour. We have covered so much in this webinar. If a chief philanthropy officer had, let's say, 2 minutes with their CEO, because CEOs are pretty busy, of all of this, what should they lead with?
Yeah, if you had 2 minutes, I would suggest focusing on the why and the what that your CEO can help with in a very unique way. So the why, of course, is the vision and the narrative behind the institution and where it wants to go and what it wants to become and how it is striving to make a bigger impact for the health of its community or the people it serves. And then the what, we talked about this in the very first data slide, which is around the priorities. What do we need investments in? What priorities are important if we are going to achieve that vision? And I think CEOs and hospital leaders are, if they're able to help answer those questions, our colleagues on the call will have much easier jobs to execute.
Yeah, I think we need big visions for exceptional philanthropy, for transformational philanthropy. It's not about keeping the lights on. It's not about plugging holes in the operation, in our operating budgets. It is about a big vision, and that big vision has to come from the top. So I've put up here a link to our survey. We hope that please take a minute just to give us feedback and let us know what you thought about the webinar. Sarah, I wanted to ask you if there's anything that you wanted to add, on the way out. I think Eric did a beautiful job of answering that, but anything you'd add to it?
I agree. Thank you so much for joining us today. Erin, thank you again for this incredible partnership and the research for our field. And I know I speak for Eric and Erin that we are happy to have any follow-up conversations. There's so much to unpack here, so much that can be applied to your day-to-day work. So thank you again to all of you for joining us.